Hey guys, I hope everybody having a good weekend, getting ready to go out there and kick some ass this week. Just wanted to do a quick video. I listened to Tim Ferriss' podcast from a couple weeks ago where he had Eric Vance on. Eric Vance is a science writer, has a new book coming out, or I think it actually might be out, on placebo, looking at placebo from a couple different points of view. But it just kind of got me thinking about the importance of placebo, the different, just like this title, the different layers of placebo, and the way that we should, from a practitioner standpoint, be using placebo in our practices to the best of our ability. We use it every day, but I don't think we always realize what we're doing. I think it's just happen chance a lot of the times, and it's more and more research pointing to that it's one of the most powerful things you can use if you know what you're doing. So the three layers I'm going to kind of talk about, and I'm open to interjections here, questions, open to debate if somebody thinks some of this stuff's different, but also put some research articles in the comments below. But the three layers would be intervention, which is for a practitioner, would be the treatment. If you're a patient, obviously that's what's getting done to you or you're having done to you. Presentation would be how that treatment or procedure or whatever's happening in the patient-doctor interaction, how that is being formulated and being shared between the two. And then the third would be the reputation, which I'll talk about that when I get to it. But let's talk about the intervention. I think everybody knows what placebo is. Placebo basically is, like I said, it is an effect, whether we are meaning to do it or not, that is caused by something that does not necessarily, actually do what it's supposed to do. So one of the best, not even recent, they've been doing research on this for years, one of the best examples is sham surgery, where they basically have a group of patients. Let's say they've all been imaged and diagnosed with a torn ACL, and they're going to go in for ACL repair, and half the sample size is going to get a sham surgery. So they still get cut, they still get stitched up, and they're still in the OR for the same amount of time. They just don't have any repair at all. So they basically just get cut, and then the other group obviously is going to have a repair. So the funny thing is that both groups have almost identical outcomes. So when you have something like that, when we look at surgery where we say, obviously we know we're actually changing structure, we're repairing something, we're grafting something, whatever it is, it's a pretty big deal that the brain can manifest alleviation of pain, change movement, and these are long-term results for a lot of these patients. So when we look at conservative care, we really have to take into account what we're doing with placebo, because we're not cutting people open, so we don't have the power of the presentation, which we'll talk about here in a second. But we have to realize when we want to use placebo and when we should actually be using, not that we're not all the time, but actually be using the intervention to get the effect we want. So what do I mean by that? Well, like I had a runner the other day, the Pinhoti 100 was this weekend, a 100-mile race here in our back door in Sylacauga. Came in, foot pain. Like the likelihood that we're going to get the runner to go out and run a 100-mile race without pain, highly unlikely, right? With one day, not even 24 hours. But if this patient's watching, this is a college professor. They're going to understand. The way you present what you're going to do for that patient is very important, because you have to give them confidence, which is part of the placebo effect. But B, you want to make sure that they understand that what you're doing is powerful, and not that you're lying to them, but sometimes we have to trick ourselves into realizing that we can change something rather than just saying this is the way it is. And an example used for that is a lot of people will go to an orthopedist, say it's a 56-year-old or 50 or 60-year-old person, and they have knee pain, and they go into an ortho and they're diagnosed with osteoarthritis. Really common, right? And then basically they're just given this sentence of, well, the arthritis is going to continue to get worse, and eventually you may need a knee replacement. You should probably stop doing any basically like running or any high load activities. Well, there are patients that go to get treated, nothing has changed structurally, but they're out of pain and they start moving different. And then there's patients that have far less severe degeneration of a joint that get told that they have extremely bad or very progressed arthritis that have far worse pain. It's just like back pain and MRI findings. I mean, we can't always correlate what's on an MRI to the pain that's happening. But I mean, so if you think about that stuff, you got to make sure as a practitioner you're using it. So in your intervention, like we all have this, regardless if you're a chiropractor that only adjusts, or you're a physical therapist or a chiropractor, or ATC or whatever, that's got this tool set or a set of tools that you can choose from. You got to make sure that the intervention is actually the best one for the cause. And I don't always mean that that's the best for that injury, because we know that a lot of different tools and techniques will get outcomes that are positive for the patient. So sometimes the intervention needs to be decided on by the history and the observation of the patient. Obviously, the history is a big player in any treatment of a patient, but what I mean by the observation is reading that patient's emotional output to you, where they're at in their injury cycle. Is it, has this been years? Is this acute? Have they been told 15 different things? Have they been treated by, a bunch of different doctors and they're at their wit's end? Or, what is it? And that's, I think, what really starts to differentiate the good doctor from the great is a lot of the times not the practical application of a technique or, a specific adjustment or even surgery. I think those things are important to be very technically sound, but I think a lot of the times it's the people that can have a high emotional IQ, right? And then be able to converse with a patient adequately and interact with them and allow them to realize that what we're going to do is going to help, but we're also not filling their head with false hopes, which sometimes that could be detrimental and good, right? We don't want to promise anything, but we also don't want to fearmonger and say, man, you've got degeneration. This is the way it is. I mean, the more we find out about pain and pain neuroscience, the more we realize that structure really, a lot of the times, is not determining pain. And if we can get people moving appropriately, I even hate to say that, if we get people moving differently and we educate them on their current situation and their pain, that's where you're going to see a lot of things change. And I think that, placebo, we think like sugar pill and then actual medication a lot of times. I think true placebo in my mind is where, and this is where I'll get to the presentation part, is where the way that you explain or build the treatment or the treatment plan, that is a big deal. I mean, if somebody comes into my office, and I'll bring up two sides of the coin here. Somebody comes into my office and I didn't talk the entire time, and I went through my examination and I just treated them. I don't think my outcomes would be quite as good. Now, all my rehab nerds out there are going to say, well, what about some of the really famous people from the Eastern Bloc that literally that's what they do? Or there's a huge language barrier where they're not talking to people, they're not explaining stuff, they go through their exam, they treat, there's very little, there's interaction, but they're not explaining what's happening to the patient. That's where we get to the third part, in my opinion, is reputation. So probably the biggest part, which it can't happen right off the bat. So say I'm a brand new doctor. My reputation has not been built. I'm not the James Andrews of whatever. Obviously he's one of the most well-known and possibly also the best surgeons in the world, orthopedic surgeons. But his reputation is the biggest part of his placebo now. And it's also the presentation when you go to James Andrews' office. If you're an elite athlete and you go to Andrews' office, you go into a different door. You get treated differently. So that perception already starts to mold, or that presentation already starts to mold the perception of the athlete or the patient that's getting treated, which is a huge deal. I mean, if you know, say you're an NFL athlete and you say, I'm going to James Andrews, and everybody you've heard of that's went to James Andrews has success. I mean, just like hanging out with successful people, success breeds success. Yeah, it does, but in our world, it's not just luck. It's how the specific treatment, like I said, picking the right intervention meets up with proper presentation. And then when reputation starts to build off of sound intervention presentation over time, then your placebo factor just keeps jacking up, or I guess the success of a placebo factor. And I may be misrepresenting a placebo by saying the placebo factor can have a higher success rate. Placebo is just placebo. But I hope that makes sense of if we understand what we're doing, we don't just say, yeah, I mean, the muscle's tight or whatever, and I'm just going to treat this thing. And, you know, I think they're going to get better, and I got an idea that maybe the 6 to 8 visits, versus you specifically educate the patient on what's going on to the best of your knowledge, a very specific treatment plan. You've got specific techniques that you can use for this. I mean, their confidence goes up. Hopefully they came into your office thinking, hey, I already heard you're really good at what you do. And the back end of that is you have higher success. So that's kind of just what I wanted to talk about, because if you can hone this, especially think about that new doctor. If you're a new doctor out there, a new grad, you don't have the reputation part. I mean, there's no way you can. I mean, we barely do. We've been here 3 years. So if you don't have the reputation, each interaction with every patient is an opportunity to build that, what I would consider the umbrella of placebo, which is building that reputation of, that's almost like, to me, you're trying to get your clinic to be the OR with the sham surgery. Not that, and a lot of people are going to take that very, very wrong. Nothing we do is sham by any means. Every technique that I use is 100% for a reason. I am not just doing stuff, because that's my protocol or that's what every patient gets. But if people come into my clinic expecting stellar results, there's a lot higher chance they're going to get that, versus Googling chiropractor or physical therapist and going to who's closest, or who has even maybe the fact that you have higher reviews on Google in this day and age starts to feed into that. I hate to say that, but as anybody who's been in our business for a while knows, word of mouth is a big deal, and word of mouth is that individual interaction of placebo in action building upon itself to where you get that bigger umbrella of a more powerful placebo effect. So there's a lot of good books out there. Eric Vance has his new book out. I'll put in the comments what the title of that book is, but I just kind of want to talk about that because I think about this all the time, and I discuss it with patients all the time. We bring up, MRI findings not matching pain presentation, especially with low back pain. We talk about arthritis or previous surgeries and how people kind of basically chain themselves to a diagnosis or a situation, and that's not the case. And that would, I don't think that's quite nocebo. Nocebo is where we're causing damage, and maybe we are by fear-mongering or wrongly educating these patients with, or not us, but whoever's talked to them before, about things that just aren't true. But I think that's the anti-positive placebo when we just kind of say, this is the way it is. Well, no. Let's educate people first, go through the intervention, the presentation, and eventually build that reputation. And I think if you can do that, you're going to get a lot better results and just continue to snowball. And that snowball effect is just, that's where, all the magic's at in professional practice. And, if you're a new grad or a new doc that's wanting to eventually go out there and do something besides treat people, say you want to go teach or you want to go talk, maybe you start to pay attention to this kind of thing, because this is something that, yeah, it's been researched for a very long time, but it hasn't been researched in conservative medicine very much. Things like taping and adjustment, soft tissue. I mean, it's hard to sugar pill soft tissue. You can't go in there and like touch one person and then just wave your hands over the other and see what happens. But your presentation can just again change everything. So maybe, I mean, you don't want to use your patients as an experiment, but you know, who's to say that if you didn't tell somebody why you're doing something, is it going to work as well? And maybe you've already found that. You know, somebody they came in the second time after you saw them the first time, they don't understand why you did something. And after you explain it to them, they come back in, whether it's, you know, you needed more time, or they understood, you know, biomechanically or physiologically what was going on, and all of a sudden like, man, I'm feeling better. I mean, I think that's a really big deal, and that's why we spend so much time doing that with our patients. And I think anybody that's on here that's been a patient of ours will know, I don't think we word vomit. We tell people what we think they need to know rather than just treating them. So I think they appreciate that, and I appreciate teaching people. So if you guys have any questions, post them in the comments here, because I haven't gotten anything live. I'm going to hang here for just a sec, see if I got any questions come in. I saw my buddy Billy commented up here. Yeah, Billy was just mentioning like the psychology of a sports injury. Psychology of a sports injury is huge, and also just to kind of piggyback on that, just like a preseason concussion assessment, I think that's one more reason to get a preseason, whether, you know, movement screen, whatever you're using, some sort of preseason, besides just the physical, a movement analysis of some sort of an athlete. Because, yeah, we're looking for injury limitation and buffers for injury and, you know, quicker return to play after an injury by doing those things and seeing where we're at on a baseline. But it also is a big confidence builder for an athlete to know that they're going into the season as best as they can, rather than just not knowing it all. And I mean, I think at varying levels of sport that may be different. A high schooler, I don't think they're thinking, because they haven't dealt with a whole lot of injuries. You get up into college and obviously professional, I mean, that's when you realize how important an injury is to your sports performance. When you're feeling bulletproof in high school, maybe you don't worry about that as much. So, but I think as we go through there, having those initial preseason assessments are a big deal. So, how much of K-tape is placebo in your opinion? I actually just looked at a study that out of the, Journal of Manual Therapy, I think. I think it was on shoulders. So I did my graduate research on kinesiotaping of shoulders too. I don't think a lot of it's placebo. I think it's novel input, which, is that kind of the same thing? But how we always explain tape to people, one piece of the taping paradigm is if you hit your head, you're going to rub your head. That's what everybody does. Or if you have pain anywhere, you rub it. Mechanoreception overrides nociception. So that stimulus is going to override some pain. It's awareness to that area. If we're working on, proprioception, whatever it is, we always tell people, I mean, I can't tell you how many people come in and they say, I've been taping this forever and it doesn't work. And you tape them, they come back and like, man, that tape was awesome. Well, we did other stuff besides tape, first of all, but we always say the tape's only as good as the person putting on the tape. Because we've been trained. I mean, usually hopefully we know anatomy better than our patients. But I also think the fact that we're putting it on versus them probably is a bit of placebo effect. I mean, it's going to up the person's, perceived outcomes or what they're expecting to get out of it. What do we got? No questions. Just want to say congrats. Thanks, Adam. Thanks, man. Not sure if you want to touch on the topic. I've seen your post about power lung or something. I was curious about that. Sure. The power lung is a little, it's right here. So this little thing, I'm not sponsored by Power Lung. Literally, I think some guy built this in his garage. You can see the Phillips head screw in there. All this is a restricted breathing device. You've seen the training masks. I'm going to tell you right now, this is where how they market it versus how it works are vastly different. So it does not mimic altitude training whatsoever. I know it's called an altitude training mask. That's not what it does. It's literally like doing curls for your biceps, but for your diaphragm. So it's going to make the primary respiration muscles work harder. So for me, I'll actually use it, like if I'm on the way to the park for a trail run, I'll use that as like a warm-up. A couple times I've got a little bit lightheaded, so hopefully I never pass out while I'm driving, but I'll use it to work on like diaphragmatic respiration with that restrictive device, so you really have to work for it. So to me, it's just like putting a resistance band on a movement, and then I'll use it for recovery as well. So if I'm trying to work on getting myself back to a parasympathetic state after a workout, and I put in a restrictive device, I can get my resting heart rate back down faster because I can basically O2 saturate a lot heavier if I just go through about 10-20 cycles with that thing. So I hope that answers your question, Brandon. It's a good thing. Again, that's just like me telling somebody, I'm doing soft tissue to break up an adhesion versus I'm doing soft tissue to put novel input into the area of your body so your brain actually knows what's going on. We're doing the same thing, and knowing why it actually is working based on the current level of knowledge, again, is a big deal to me, whether it's a big deal to the person that I'm doing soft tissue to or that's foam rolling or whatever. All right, I guess we'll finish the questions there. That got a little bit off topic, but that's kind of fun to talk about. I'm going to try to do a video like this or a Facebook Live every Sunday. I'm also going to post these on our YouTube channel afterwards so you can go and watch it. If you guys have any ideas, private message me. I'm more than happy to cover topics that, whatever it is, injuries, human performance, for my colleagues out there, anything business related, I'm always game. Thanks for joining me, guys.